Thank you, and it's a great pleasure to be here. Now, I was a bit disturbed when I went to do my talk recently. I started it and then thought I'd better check last year's and realized I was repeating myself. So I then had to think of something novel to say. This is definitely novel to me, what I've put together, but it's a bit of a hodgepodge, so we'll see how successful it is. And I apologize in advance for the quality of the slides. There was a Mac to PC transfer problem and a 6x4 to 16 times 9 transform problem, and I've only had a few minutes to rectify it, so we'll see. You can complain if you like. There are the usual conflicts of interest. I am conflicted in many directions, but I try to be objective. I plan to talk about some tests and some drugs and some dermoscopy and some random other things. I'm going to start by talking about fungal toenail infections. They affect up to 60%, depending on your age, of adults. And they cause some grief to your patients, and others ignore them. So there are many types of onychomycosis, but the most common are distal subungual onychomycosis and white superficial onychomycosis, and the usual organisms are the trichophyton rubrum and Mentagrophytes, but there are others. So why should we treat them? Well, the main reason is they're ugly. So they can be various colours, broken, lifted, and occasionally painful. And these affect social interactions and what footwear you can wear. Problem in diabetics because they increase the diabetic complications because of pressure ulceration and secondary streptococcal cellulitis. So what are the options for treatment? Well, you can try removing physically the bits that are dead, or chemically, not terribly successful. Recurrence is usual. Topical therapy. Well, amorolfine nail lacquer and cyclopirox nail solution are funded options for distal onychomycosis. Over the counter, you can buy myconazole tincture, organic acids, tea tree oil, and undecalinic acid, but myconazole is the only one that's supposed to work of that group. There are new topical options that are more effective that are marketed in North America and Japan called efinaconazole, which is all of 15% effective. Well, that's better than the current ones, but it costs more than $500 a bottle. Or tavaborol, which unfortunately isn't quite as good as the efinaconazole and is around a competitive price. So watch out for these miracles on the horizon. So when should we use topical therapy? Well, we use it for mild distal and lateral infection if there's a contraindication to oral treatment. The patient has to be patient. They need to apply their treatment daily or more or less daily, sometimes weekly, depending on the product, for 1 or 2 years before they can decide if it's making any difference. So, this is what Pharmac's thingy catalogue tells us, that you can use Myconail, this one here, $45.37, they're paying for that, for a big total of 5 mils. You use that one once a week. Or you could use cyclopirox lacquer for $11.95. So they're fully funded by Pharmac, but not terribly effective, but better than nothing. There's an organic acid out there, which I didn't list previously, that has got evidence base to suggest it, and it's similar to Loceril, which is a brand of amorolfine lacquer, and it doesn't contain a standard antifungal. It's got some other things listed up at the top. and costs $69.95. Why am I going on about price? Because it's very important. Now, another study looking at the same organic acid came to the conclusion that it didn't work. So patients often ask, when I'm using this lacquer, can I put on my usual paint? And the answer is yes, it doesn't stop the useless lacquer continuing to be useless. According to this study. But what does work in 76% of people under the age of 60 with mild distal onychomycosis, so the same group, so we're comparing mild disease versus mild disease, 76% treated with oral terbinafine will clear with a 3-month course of 250 milligrams. Now, up until now, we've been recommending oral medicine for the more severe disease rather than the mild disease. Now look at this price. $1.50 for 14. That's incredible. So why would you pay, or why would Pharmac pay what it does when it can buy Dr. Reddy's terbinafine? So there is liquid formula instructions in that same catalogue to tell you how to give it to children. So its rival is itraconazole, which was also effective, not quite as effective, only 60%, in mild distal onychomycosis in the under 60s. Now, note that age. The studies have not been done in anyone older because their toenails grow too slowly and their disease is too severe. We do not know what the efficacy is, and there are drug interactions, particularly with itraconazole. So all these drugs are no, sorry, you have to have the next page is on the interactions. You have to have endorsement by a specialist still. I've no idea why, but I'm sure Pharmac have got some good idea. This is also extremely cheap these days, $2.99. Used to be very expensive, of course. Now, in distal onychomycosis, it's only used where terbinafine is either not working or contraindicated. And you have to have a specialist agree to that. So, mycology, of course, we all want to know, is it a fungal infection or not? And over the years, I have instructed those who listen, they must do mycology before prescribing anything for toenail infections. And there's some instructions here that you're familiar with or can look up on DermNet how to do it. And this paper came out very recently suggesting that you shouldn't bother with mycology. It's a waste of time, money, and space. And this is much too busy for you to see, but at the end it says that you'll get some false positives and some false negatives and some true positives and true negatives from mycology. And this team think you should do the test first because you shouldn't give a drug to a patient that doesn't need it. They might not have a fungal infection, they might have psoriasis. The treatment might not work. They might be old or infirm or have immune suppression or diabetes, all features of making your fungus not respond to treatment. And drugs are toxic. People die from oral terbinafine. It causes agranulocytosis, it causes hepatitis, and it causes toxic epidermal necrolysis. But these are actually extremely rare. But it might be you. And I'm talking really rare, but if you've seen it, you're soon biased against these drugs. So do your mycology first. Adverse reactions also occur to itraconazole. The hair might fall out. Actually, not very many adverse reactions, but what happens with itraconazole is this is only a few of hundreds of other drugs with which it interacts. The main one that you have to remember is statins. Terbinafine's interactions are a little shorter. There's actually very few interactions with terbinafine, but it does have adverse reactions like taste disturbance and various rashes. This alternative view I'm beginning to believe in, that you don't do mycology. Why not? Disease prevalence is 75% per patient. Cost savings of empirical terbinafine therapy without confirmatory testing was $47 US, compared with, if you did do testing, of $135 US. The cost of testing necessary to prevent a single case of clinically relevant liver toxic effects related to terbinafine at that prevalence was $18 million US, and $47 million US for PAS testing, which is histologic. So, enormous amounts of money could be saved in the US by not doing the testing. So I did the cost analysis for an equal group in New Zealand. So 12 weeks treatment with terbinafine costs $9. 12 weeks treatment with 200 milligrams daily of itraconazole, and most people only give it for 1 week a month, is $36. If you ask the local lab to do a test, you need an extra $118, 83. Makes you think. Children's options are the same. They respond better to oral terbinafine than adults because their nails are less infected and grow faster, but they do need a dose adjustment. Now, your test will pick up sometimes these peculiar things that are called molds, and they don't respond to terbinafine. So what you could do is give the terbinafine without doing the test. It didn't work, and then do the test. But you have to wait probably 6 to 12 months before testing, because the terbinafine's still going to be around, so you could easily get a false negative because of the presence of the drug. And we don't know how to treat this, but we throw everything at it, and sometimes we see about 10% improvement. Should you use medical nail avulsion with 40% ureacrease? Perhaps. You can find out how to do it on DermNet. Should we use laser treatment instead? I see there's a stand at this symposium promoting laser treatments. They were FDA approved, and that's because the safety of the laser is not in doubt. It's been used for many other indications. It's a neodymium YAG laser. But they didn't look at the efficacy. So there weren't any efficacy studies when the FDA approved it. You can see some dramatic before and after pictures, which look impressive, but I gather they don't often actually achieve those results. The idea is that you kill the dermatophytes by heating them up so that they basically burst. And you only have to do it once or twice, and that's the end of them. Does it work? Well, there's very little evidence, but there's a little bit of evidence and more coming. So probably lasers are here to stay, and they are suitable for some patients and may work when oral treatment is contraindicated. At the moment, they're pretty expensive, so the average patient's probably paying about $1,500 for 1 or 2 laser treatments. I suppose people have to pay for their machines. Just be aware that you can get a bit confused when you're preparing a presentation on this topic, because a brand, everybody knows this particular brand, but branding, you kind of get used to a particular product being containing clotrimazole, and then it comes in with the same brand, but actually it's a different drug. We've got bifonazole here. So just be aware that the brand doesn't tell you what product it is. And equally, if you do a search on Mycology, which I'd never heard of before last week, you actually come up with this Mycology, which is a completely different product by a completely different company, but not available in New Zealand. So what about topical steroids? Well, topical steroids are equally confusing. We have a poster on our wall in the Department of Dermatology which illustrates the creams and ointments available, but after about a week of this poster being up, we had a lot of patients shaking their heads and saying, no, I'm not using any of those, and we're beginning to think that their GPs have been prescribing them water or something. Well, they said it didn't work, you know. That's because they only put it on once and they didn't get a miracle cure, but they thought it was the brand that was no good. So a pharmacy opened in the Mead Centre at Waikato Hospital about a month ago, so I popped in there and said, could you show me your funded topical steroids? And we changed that one, 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 and we changed this one. So we have to have a new poster now. So be aware, please use generics. Try very, very hard to use generics. It'll make your life much easier in the end. Let's look at clobetasol. So the new funded clobetasol is this one. It's very simple. It says it's called clobetasol. It's really helpful. Whereas the old one said it was called something unmentionable, which is a moisturizer. So we had a number of British patients come along and say, I'd like one of those big bottles of Dermol, please. Big bottles. You mean for your scalp? They're about this size? No, it's about this big. Very confusing. Are they safe? Well, there's a lot of evidence to say that they're safe, used properly. So contrary to popular perceptions, this is a quote from this recently published article on the safety of topical steroids in children with eczema, a consensus document. The topical steroids don't cause atrophy, hypopigmentation, hypertrichosis, osteoporosis, purpura, or telangiectasia when used appropriately as per guidelines. I'm much to blame, of course, because Dermnet is full of what happens if you put too much topical steroid on and lovely illustrations to terrify people. What is appropriate use? 1 to 2 generous applications per day to all inflamed skin until the active eczema is controlled. There is no requirement to use sparingly. So sparingly is written on every tube. Please tell your patients to ignore it. If you want to get control of active flares of eczema, they have to use it generously, just once a day, and to all affected areas for 2 weeks. There is no requirement to use sparingly. So fingertip units. So become familiar with those. They're on Dermnet. That's a fingertip. And it depends on the size of the individual. So a child having a fingertip unit uses the child's finger. Should you dilute them? No. You should use moisturizer. Dilution does not dilute the strength of the topical steroid. It just mixes with some unknown emollient with unknown effect and reduces the expiry time. So there is no point in thinking you're clever by giving 2% hydrocortisone cream because it works the same as 1%. It doesn't in the first day. The stronger one works quicker in the first day, but by day 3 there's no difference at all. So I'm expecting you to all read that in absolute detail, of course, but the article is worth a read if any of you treat a lot of eczema, and I'm sure you all do. It's in the Australasian College of Dermatologists February edition. So these side effects on Dermnet are rare in children. They're pretty rare in adults, but I would see 1 or 2 cases a year of overuse of topical steroids. But when you hear how they're using, you shake your heads. And you wonder who is prescribing clobetasol 2 tubes per week. So those patients, we have to test their adrenal function and various other things. Contact allergy does occur. It's rare, but we do see that from time to time. The contact allergy may be to the preservative or a vehicle, or to the steroid itself. Very difficult to diagnose because steroids have an anti-inflammatory effect, so you may not be able to appreciate that they're also having a pro-inflammatory effect. We patch test to find that out. Periorificial dermatitis is a real common side effect from topical steroids used on the face. Relatively easy to treat if you're aware of it. It occurs mainly in young adult women, and it settles by removing the cause and treating with doxycycline, 50 milligrams once daily. That's not funded, so 100 milligrams alternate days, or in children, erythromycin, 400 milligrams once daily. So, does a small dose of doxycycline actually work? Yes, it does. Now, we're worried about using tetracyclines for skin conditions. Rosacea is a chronic disorder people have for decades, and they're continuing to use doxycycline because it works for decades. Is that safe? Is that appropriate in 2016? So there's been some studies to show that if you're using 40 milligrams, an American strength, that's sub-antibiotic and you don't induce bacterial resistance. So we're assuming in New Zealand that 50 milligrams might be pretty much the same as 40, but there isn't data for that. If we can, we should be using a topical agent that counteracts bacterial resistance. And in acne, that's going to be either benzoyl peroxide or topical retinoid or both. But in acne, most patients these days are having topical therapy, and if that doesn't work, either combined contraceptive or isotretinoin. And we should be only using doxycycline in acne for maybe 3 months, whereas we used to say, keep going for years. We don't say that anymore. So in rosacea, that's really the place for low-dose doxycycline, and it's been shown to be just as effective. You can also get minocycline on special authority application for rosacea. And isotretinoin is also effective in low dose for rosacea. How does it work? Well, it just does, and you can read about that on DermNet. It's all about metalloproteinases. So what about extemporaneously compounded products and galenicals? Well, there's small print in the catalogues that many of you probably don't even know what it's there. But it explains that you are allowed to make some special mixes, and if you do, Pharmac will contribute to the cost. But they will only do that if you have the right 2 ingredients, or 3 or 4, or however many you decide to put. So in this case, we are told that you can dilute a topical steroid. I've just told you not to do that, but you'll get paid. It'll be funded if you choose to do that. You can apply menthol at 1%, that's helpful for itching, in aqueous cream, which causes itching, so that's not very logical. Urea cream, which also causes itching, so not very logical. Wool fat with mineral oil lotion, which I frequently recommend because it's sloppy. They can put it in the fridge, so menthol in a cold lotion will relieve itch quite nicely for at least 30 seconds, sometimes as long as several hours. You can use the same lotion that's got hydrocortisone in it and a lotion without the wool fat as well. But if you put it in anything else, for example, cetamacrogol cream, it is not funded. Barrier creams. Well, we've got barrier creams are useful for hand dermatitis, dribble rash, napkin dermatitis, and incontinence in adults. And this is new. These are now subsidized. So that's worth knowing. Zinc and castor oil. Now, you get a big pot, but that's your only choice. Zinc and castor oil, you imagine putting that on your whole body? Not good. But it's very good for small places, but 500 grams it is, but it only costs $3.83. Emollients for dry skin. There's a new thing come in, which means that the aqueous cream no longer has the irritant in it, So that's very new that Pharmac is subsidising that, and I think that's next month that comes in. And that's going to be very useful. So a soap substitute that's less irritating and can be used as an emollient. This product is very, very popular with patients and with the dermatologists as well because it's in a pump pack. So you imagine having infected eczema, sticking your finger in the pot, which is a cream, therefore you could grow bugs in it over and over again. So at least with the pump pack, we're not sticking our dirty fingers in the same pot every day or several times a day. So if you look at subsidized mixtures a little bit more carefully, you find there's a second list where if you're a dermatologist, you have a longer list of options and some other products you can put in there. So you will see prescriptions from dermatologists with more complex mixes, e.g. for scalp psoriasis, Lycophysis carbonis, salicylic acid in aqueous cream. So we're using aqueous cream there because we can wash it off. So it's applied a couple of hours before shampooing and then washed off. Nicotinamide. Nicotinamide is B3. So you can't prescribe it in an adequate dose, but it is needed for certain coenzymes used in oxidation reduction. B3 comes in two forms. It comes as nicotinic acid, or niacin, and nicotinamide, which is also known as nicotinic acid amide, and they are different. They have different properties. So this one is used to reduce cholesterol, but unfortunately patients taking that complain of flushing, and it can be a real problem. This one does not cause flushing, but it's no use for your cholesterol. It's an anti-inflammatory if you give a big enough dose, and it was originally used in dermatology for the treatment of bullous diseases in the elderly, trying to get the prednisone dose down as low as possible. We haven't used it here because we can't get it. Anxiolytic, I don't know how it works with that, but it's been used for a number of indications with some weak evidence to support it. It is toxic at 3 grams per day. The only way you can get it is really by going online, and Fishpond bring it in for you from the US. It's a general sale medicine, so it's legal for them to do that. If you prescribe it as a multivitamin, you're only getting 20 or 30 milligrams max. But in order to treat for dermatological indications, we need 1 gram a day, and these doses are not useful. So we have a recent study, several of them actually done in Australia, have now promoted the fact that nicotinamide reduces actinic keratoses and squamous cell carcinomas by 20% or so, which if you're somebody who has multiple actinic keratoses and squamous cell carcinomas might be considered useful. So they can go out and buy it. It's quite cheap. It's not, it's not expensive. It's just awkward to get hold of. So Fishpond sell for $60, healthier.co.nz for $20, and little bit less from mydailyvita.com. Now, these are imported. I have no idea if they contain the medicine or not, or whether they're just made of lactose. But the label on the outside suggests that they're regulated and full strength. But do bear in mind that there's no point in giving this to people who aren't protecting themselves from the sun, and that your advice to protect from the sun is far more important and can protect far more than 20%. So absolute sun protection is the treatment for multiple actinic keratoses and multiple squamous cell carcinomas. And only in those patients am I bothering to say, well, the extra thing you can do is to swallow this stuff if you can get it. Urticaria, pretty common. There's been a new study endorsed by the American Academy of Dermatology that there is no need to do any tests at all for your patient who presents with urticaria. Now, dermatologists in New Zealand have never tested for urticaria, but we know that most of our patients come and they've got huge pieces of paper that they bring them to prove that they must be terribly unusual because they've had 100 tests and they've all been normal. And what could possibly be wrong with them? So please don't. Urticaria does not require tests. It requires a history and a clinical examination. Now, if they happen to have some other symptom that requires testing, please go ahead. For example, if they're febrile and you're worried that they may have some serious disease underlying this fever, you might wish to do something like a CBC, but don't do it because of the urticaria. Now, if there's something a bit odd about the urticaria, like it's leaving bruises behind, you might want to biopsy an early lesion, and that can be helpful to look for vasculitis. But there's no point in a typical urticaria that's effervescent, and it's no point in an acute setting. We're talking about a chronic urticaria. You're waiting for an outpatient appointment, and there's something a bit odd going on. They might have some arthralgia or some intermittent fevers or something else that indicates this isn't ordinary urticaria. So this patient had urticarial vasculitis. They had a swollen knee. I don't think it looks very swollen in that picture, but it was effervescent. And they had an effervescent rash, which left a few bruises behind. So we're looking for the edge of the red patch, the new part of the urticaria. This one outside was done for direct immune fluorescence. And you do that just outside the urticaria patch, if you can get that done locally. Now, urticaria has enormous morphology variations, and just because it has target lesions doesn't make it into erythema multiforme. That's a completely different condition. But urticaria is the most common reason for target lesions, and to try and differentiate, we call it target-oid. But this patient was referred to us with typical erythema multiforme. But this was changing by the minute. We can use antihistamines. There's no point whatsoever in prescribing anything other than cetirizine or loratadine. The old-fashioned ones do not work better. They do not work nearly as well as cetirizine and loratadine for urticaria. So although this is subsidized, I do not recommend it. Now, you might decide to use it as a sedative, that's up to you, but it is not useful for urticaria. Now, the one that's the star at the bottom that hasn't come out, that is fexofenadine, and I believe Pharmac is about to fund that too. Fexofenadine is effective, but not as effective as cetirizine and loratadine. So what dose? Urticaria responds to 10 milligrams in a certain proportion of patients, but some of them need 20 milligrams, 30 milligrams, or 40 milligrams. And please don't call me about your patient with urticaria until you've escalated the dose. The type 2 antihistamines, that's cimetidine or ranitidine, do not work for urticaria. They've been very popular for about 15 or 20 years with absolutely no evidence to support their use. What do we do with chronic urticaria? We give them the same drugs we use for other chronic inflammatory skin diseases. They're slow to work, but they work reasonably well. So we're talking about methotrexate and cyclosporin particularly. Not prednisone. Not prednisone. You can use prednisone for a few days once in acute urticaria, just to help you not feel quite so desperate. The patient will continue to feel desperate with tremors and sometimes delirium. This drug is an anti-IgE. It's registered in New Zealand and funded under certain circumstances on special authority for asthma. It is not available to us yet for urticaria. But it works. In the last few minutes, I'm going to rush through two other things, at least. Chaos and clues is the new way in Australasia of learning dermoscopy. I can teach it in a few slides, but it requires a lot more practice. Get one of these posters, study it carefully, learn the elements, which are lines, dots, clods, and if you haven't got those, it's called structureless. Put these together in patterns, so patterns of lines, patterns of dots or clods, or structureless patterns. Decide what colour your elements and patterns are. Are they brown, black, grey, red? And decide if you're going to cut the lesion out. You're going to cut it out if it has chaos, which is defined as asymmetry of structure and colour and more than one pattern, or any of the 9 clues. Chaos? No. That's symmetrical. Yes. Lots of patterns and clues. The new clue is large polygons, which are a special Australasian variety of melanoma that's not seen in Europe because they haven't killed their upper backs quite as badly as Kiwis and Australians. And a large polygon is formed by lines that can be any colour. We've got quite a few polygons in different colours in this melanoma. Atypical lentiginous hyperplasia is in effect a melanoma. So if you get that report, treat your patient as if they had a melanoma. It will be if you leave it long enough. It's a pre-melanoma, it's growing, and it will become, especially if you see polygons. So chaos with a polygon, take it out with a 2 millimeter margin. DermNet is my very last point. In a month or so, DermNet is going to look different. I hope it doesn't look too different to you. It will have the same content. But after 20 years, it is time to modernize. This has been a lot of heartbreak and some money. The concept of DermNet goes back more than 20 years, and we launched it exactly 20 years ago as New Zealand DermNet under the umbrella of the New Zealand Dermatologic Society. It's now a charitable trust and independent of the society. We've added social media, and it looks pretty much like it did in 1996 and 2001. 2006 and 2016. So I'm very conservative, really. Why change? Well, I'm getting a little bit grayer. My children have grown up. They seem to think I shouldn't be working at midnight. Succession planning. I can't find anyone to take over, so if anybody in the audience is interested, please come. But who knows HTML coding? Who knows image processing? But we don't need those anymore because of modern technologies taken the need to understand programming away from ordinary people. Second reason is the rise of mobile. Dear webmaster, Google systems have tested 2,820 pages from your site and found that 100% of them are completely and utterly useless. Well, that made me, and it said, fix this now. $30,000 later and still counting. We will have a new DermNet with the same content, but it will be mobile responsive. And yes, I do need more sponsorship and advertising, so please promote that, over there. Tell them how much you're using the site and how important it is to you. And you will see some improvements that I hope are of use to you. And it's going to look a bit like this. We won't have that picture in it, but that's more or less what it'll look like, pretty much the same. You're going to see some enhancements to differential diagnosis, some tools. You can buy images if you want, and various other things. So we've left a few minutes for questions.
Thank you, Amanda. That's fantastic. We've got good amount of time for questions, but just if you have a question, we need to get the microphone to you, or if you're towards the front, then jump up and use one of these. Yeah.
So your patient comes in and says, I've got manky toenails.
Could you tell me who you are?
Oh, I'm Sue Beelby, I'm a GP in Auckland. Thank you. They've got manky toenails, they want you to fix them. So that's all very depressing, and why would you bother? Could you just tell us what you would say to that patient? What's your little patter, and what would you send them out with?
Well, I try and find something else to concentrate on. But basically, I need to know what disturbs them. And sometimes that's fairly random and not going to be fixed by pills. I tell people that are old that there's no treatment will work because their nails are growing too slowly. I tell them that the drugs are potentially harmful, and do they really want to swallow something for a long time. I don't recommend topicals, except for in people who absolutely insist upon treatment but are, for one reason or other, not able to have pills. And then I justify it to myself by saying at least we're stopping it spreading to the next toenail, but I don't even know that's not evidence-based. I don't know if that's true. And I only read that article, well, in fact, actually I read that article a long time ago because it was published about 3 months ago. And it's been in the back of my head thinking about it, but I thought it was wrong. I thought, well, we really should be testing before we give people dangerous drugs. But then I did a test on myself, and the next day I got an email from the hospital. Dear Dr. Oakley, you're not allowed to test yourself. We're sending you a bill for $72. And then I thought, oh, well, I didn't really need that test. I knew what was wrong with me. I just wanted to, cross the T's and dot the I's. And it made me think, how many other people have I done that very same unnecessary test on when I knew exactly what was wrong with them? Either they did have it or they didn't have it because of the clinical symptoms. So I think we do an awful lot of unnecessary testing, and it costs an enormous amount of money. And we just all need to just think about that in our daily work. But I haven't answered your question because there isn't an answer to it. But I'll take another one.
Sandy Moss, GP at Waihi, had a 42-year-old lady come in the other day asking for her winter dose of Roaccutane. So her story was that 10 years ago she had terrible...
Sandy, can I interrupt you? I've already said that I don't understand trade names.
Isotretinoin
Thank you.
tablets.
Roaccutane has not been available in New Zealand for at least 10 years. It
shows how old I am.
In fact, it's not even manufactured and hasn't been for about 5 years.
Anyway, she was on one of those products 10 years ago for 2 years from a specialist, in doses enough to give her the dry skin, lips, etc. And for the last 2 years, a GP, not our practice, had been giving her 10 milligrams of Orotane to be used 2 or 3 times a week during winter, not in the summer, because it gives you photosensitivity.
Oh, Orotane's not funded anymore. Actually, it is temporarily because they couldn't get the isotane. But yes, that's a good idea.
Yeah,
not a bad idea.
I declined because I said I hadn't seen it used that way, and I would take advice. So here's my advice, please.
Oh, as long as the patient's not going to get pregnant on you, why not? It works. Safe drug, effective drug. The feelings about isotretinoin have really turned around with Professor Rademacher's work, and I suggest you read it. So it's another drug where no testing is advocated apart from pregnancy tests in those at risk. Low dose, as needed. Come to the microphone if you want to.
Merkel, GP in Auckland. Quick question about monitoring for terbinafine. Like, would you do baseline LFTs and blood count, or what's your...
Do you normally do a baseline LFT for an incidence of 1 in 10,000?
No, but that's why I'm asking, because it's sort of what we've been doing.
Now, how much does a CBC cost? Or an LFT? So I'm suggesting that you monitor with a good history in clinical examination, and in patients at risk of hepatitis because of other drugs or pre-existing liver disease, that maybe those patients should be monitored.
Rosie Fenwick, Wellington. I have a young man, he's 17, it's the ball season. He has chronic acne, which doesn't respond to face washes or doxycycline particularly well, but responds perfectly well to 10 milligrams of isotretinoin, which he's now been taking for 2 years, and which he really does not want to stop, because as soon as he stops it, his skin breaks out.
He's very sensible.
Thank you.
Fantastic, thank you. That's great, thank you very much. Can we join in thanking Amanda for a very informative session? Thank you.